joining us. FYI, this is recording. So good morning, everyone. My name is Meredith O'Connor and welcome to today's programming. We're so glad you're here. For those of you who don't know me, I am Meredith O'Connor and I'm the program coordinator, St. Louis program coordinator for the Myasthenia Gravis Association. If you're new to the MGA, we serve those impacted with myasthenia gravis in Kansas, Missouri, and Northwest Arkansas. We also have our executive director, Allison Foss, joining us today. But before we jump into our programming, we wanted to make sure that you're aware of other upcoming groups we have going on. So on Monday, August 16th, from 6:30 to 7:30 is our standing virtual meetup, which the topic for Monday is emergency paperwork and medical ID tags. Each participant will get a copy of our brand new emergency medical card, and Lawrence Hope will actually be joining us to talk about ID tags, and we hear there'll be some prizes, so that's something to look forward to. Tuesday, August 31st from 5:30 to 7 is Dr. Mamitha Pasnor from University of Kansas Medical Center. She'll be joining us to talk about COVID-19 antibodies and hopefully answer some of those questions you've all been having. If you want to attend either program and have not already RSVP'd, you can reach out to Allison and let her know. Now, without no further ado, we want to introduce you to Dr. Ghazala Hayat with St. Louis University. I have the pleasure of working with Dr. Hayat every Tuesday at our MG clinic at SLU Hospital. Dr. Hayat is a professor of neuromuscular diseases in the Department of Neurology at St. Louis University School of Medicine. And as a reminder, we just want to let you know this is webinar format, so if you have any questions throughout the program, please put them in the chat. If there's something you don't understand or want clarified, I will go ahead and ask that question to Dr. Hayat, but preferably we are going to reserve questions for the end of the presentation. So without further ado, Dr. Hayat, the floor is yours.
Well, thank you very much. Thank you for this inviting. And I always enjoy talking to the patients and the families. And as Meredith said, if you have some burning question, feel free to stop me. I usually can catch my train of thoughts. So what I was asked to talk about, basically side effects of therapy in myasthenia gravis. And so what I did, I just added a little bit of benefits. I mean, if we just talk about what are the side effects, you might think that these medicines may have more side effects. Let's see. Okay, so my disclosures, I'm a speaker for Lexion, CSL, Argenx, and Kaba Fusion, and I'm a consultant for Lexion, CSL, and Kaba Fusion. What are my objectives? I'm going to describe very briefly, because that's not the main thrust of the talk. What is the pathogenesis of myasthenia gravis? Then describe symptomatic immune modulating therapies. As I said, I'm going to even spend much less time on that, but I'm just going to give you dosage and why we do it, and very briefly. So don't get really, even when you see all these, pictures and slides of immune complexes, it just makes even residents and anybody just like too much detail, but I try to keep it very simple for you. And then basically we're going to talk about side effects and what are the possible remedies and therapies. And before I start, I always say that every medicine we take, even what we call, it's like a natural or anything we take will have side effects, or can have, can have side effects. If we always weigh the risk and benefit of that. And my favorite, it's a couple of sentences that any patient, what are the side effects? I don't think these side effects. And I said, well, just look at the side effects. Maybe Tylenol or aspirin in the PDR is like a small print in almost 2 pages. It's so many side effects. When we talk about side effects, it means it's a possibility it could happen. When a drug is approved here in our country, as FDA looks at it, benefits and risk ratio, there are some medications which will have black box warning, and I will go over that one of that for myasthenia gravis. That means that we have to be very careful. We need to choose those patients and make sure what we're doing. And anybody who develops side effects That's why we monitor patients. We can immediately stop the medication. Our aim is that patients don't develop side effects, or side effects are much less compared to what the benefits are there. And if we can give some remedies and patient can get the good results from that perspective. Okay, so this is like a brief, pure myasthenia. Most of the time you think about it, and I'm just going to keep it as a very simple. So this is the cell coming from the spinal cord. And also just we can think about from the brain coming in, this is the nerve which goes and makes this connection to, these are our muscle fibers, they're making connection. So if we look at this, which is what we call neuromuscular junction where myasthenia affects, that's where it is. This is what we call presynaptic. Synapse is where it's a connection between two different, either two nerve fibers or nerve and muscle or different tissues in the body. So this is presynaptic. And we have these synaptic vesicles, which release this acetylcholine, which go and make connection with what we call acetylcholine receptors. Once they make connection, it opens up those gates. And what happens is this muscle contracts. So simple thing is, I just want to even do this. It's just going through the whole process. It causes it. And then they're taken back, they are broken down. And so that this process keeps on going on. Now, what we have, what we call immediately available quanta, and then we have delayed, So if patients have myasthenia or any weakness, what will happen is that if you're doing day-to-day activity, you might not have symptoms because these are pretty much there and will take care of any actions. But if you need repetitive or you get tired, these get depleted because most of these receptors are destroyed because of the antibodies in myasthenia gravis. And then once we rest, the symptoms get better because other quanta come into place. And as you must have, because myasthenia, you might have heard about it. Another one is after acetylcholine receptor is the MuSK antibodies. And we also have the LRP40. And we're also looking at the agrin and other that can cause patient to have myasthenia gravis. So I said, basically, it's myasthenia gravis is caused by autoantibodies, which are targeting the neuromuscular component. And the most common we know is acetylcholine receptors, and then MuSK antibodies or muscle-specific kinase. And then the third one is lipoprotein-related peptide. So we check for acetylcholine receptor binding. Those are the most common. If those are negative, we'll check MuSK. And then if that's negative, we can go and check for LRP4. There's some presentation difference, and depending on that, sometimes in the beginning, we might order a couple of those at the same time. Now, basically, what is myasthenia gravis? Just briefly, it's an autoimmune disorder. Young women more than males. Any immune-mediated disorder is more common in females. It could have association of other immune-mediated disorders. So patient could have thyroid disease, could have thymoma, which is a tumor of the thymus gland, or they could have SLE or lupus-like. And basically what happens is ocular, your eye muscles, bulbar muscle, I'm going to show you a few pictures, and breathing, and proximal arm. So that's why you have like difficulty combing hair, or patient have difficulty getting out of chair, climbing steps. And I discussed that briefly. Fatigability upon repetition, because if you keep on doing, you're depleting all those quanta, which I showed you. And because they're not in a normal person without myasthenia, even if they're repetitive movements, the receptors are intact. So those quanta keeps on coming and keeps on making connection, and the muscle contraction keep on taking. So patient reflexes are normal. Most of the patient, we will do repetitive nerve stimulation, which will show us decrement, which is basically exactly what patients show on clinical examination. And as I said, serologic, most commonly we see acetylcholine receptor antibodies. Basically, we discussed that the weakness is more proximal than distal. And most commonly, we see eye muscle involved. And even if patients have generalized myasthenia, but almost 70–80% will start with eye symptoms. And so we could have ocular, we could have generalized, and combined with that. So patients could have ptosis, which is a drooping of the eyelid, or the diplopia, which is the C double. So patient might have difficulty breathing, speaking, swallowing, or as I said, proximal weakness. And we discussed about the fatigable weakness. What is the epidemiology? Incidence is 8 to 10 per 1 million. and prevalence is 150 to 250 per million. How do we make the diagnosis? I put it there is clinical. No matter, sometimes what will happen is your antibodies are negative, the repetitive nerve stimulation, and some patient might undergo single fiber EMG, though all those negative. But if history and some of our exam confirm it, you can make the diagnosis of myasthenia gravis. And I will go over the treatment, the new one, which is hopefully coming to the market soon, where the patient, what we call seronegative, would be also treated. So repetitive nerve stimulation test, we went over that. You give train of some stimuli and see if there's a decrease in the responses. Single fiber EMG is also an EMG test, which looks for if there's a fatigue at the neuromuscular junction. Edrophonium test or tensilon test, some of the patient might have had it who had myasthenia for a long time. It's basically rarely utilized due to there was some risk that it might cause some, bradycardia, low heart rate. And initially, I would say 30 years, 25 plus years ago, we used to do this test routinely on patients we thought that they had the myasthenia, and it will show immediate improvement. Because of those possible risks, it's not being done anymore. And I'll show you what test we do now. So the next test is the ISPEC test that most of the patient will undergo. It will show improvement in the droopy eyelid. So this is basically, you ask the patient to look up, and this is like the eyelid should be above this, what we call limbus, or where our iris, the darker part, meets the whiter part. That's where the upper lid should be. But on this side, it's almost halfway through that. And then once you keep on looking up, you start closing the eye, and then it completely goes eye. And if the patient rests for a little while, it will improve. So that is basically called ptosis. And this is the ISPEC test. The patient has the left ptosis. You put the ISPEC usually for a couple of minutes. And then once you take it off, it improves. And the patient with myasthenia, they know this, that in summer, the symptoms are worse. In winter, your symptoms are better. And that's because of the conduction and everything. So this is basically did that, and it improved your connection between your muscle and nerve. So basically, touch base briefly, but I'm going to go over that. So these are the quanta we talked about, and I'm going to show you where those antibodies, so acetylcholine receptor antibodies, these are like kind of a tunnel they make it. This is the one could be affected. Then MuSK antibodies could be affected. And then also LRP4. These are the one. And as I say, agrin and all those could have some involvement, and patient could, because that's where they're making connection with the muscle, and patient could have weakness from that. Now, binding and are much more common than blocking and modulating. So as I say, seen almost 70–80% of the patient that you will see in myasthenia gravis. In a generalized myasthenia, it's almost 9 out of 10 patients would have these antibodies. That means 10 out of 100 will not have it. And those are the ones we check for MuSK and LRP4 antibodies. If patients just have eye symptoms, the antibodies might be just positive in half of those patients. And that's what, remember I said, it depends upon our clinical diagnosis. That's another very important I want you to put there, is that your antibodies level do not correlate with severity of the disease. So one patient's antibodies of acetylcholine 2 may manifest with very severe disease, and another patient's antibodies of 10 may be just mild. This is like for each patient itself. Once we make the diagnosis, we rarely check the antibodies again. Then we treat according to the symptoms and any other presentation. We do not go and look for the antibody titers, because that just does not give us any direction where to go from there. And then the MuSK antibodies, which is here, this one will be affected, which is connected to the muscle end plate. This is the muscle end plate. We're looking at this. This is the nerve, and this is the synapse, and that's where we're making connection. So let's go to the management, and then we're going to go over the side effects. So when we manage the patients, there's a supportive treatment, okay, and or management, and which is classically is the pyridostigmine or mestinone. Most of the patient take that. Right here, I'll go over that. So acetylcholine receptor inhibitor, that's what it is, pyridostigmine or mestinone. It does not modify underlying disease process. It basically is so it just, and maybe my personal bias, I tell you, is why I still treat patients with immune modulating therapy. The reason is the pyridostigmine or mestinone is like, let's say I give example that a patient had pneumonia and had high fever and they have an infection, we give them also Tylenol and antibiotics. If I just give Tylenol, the fever will come down, but the pneumonia is still there, it's not gone. So patient might feel temporarily good, but the actual process is ongoing. So the same way when patients are giving pyridostigmine, it is helping you to have that acetylcholine longer in that synapse or the cleft for longer period of time, so it can make connection with more receptors. But it's not doing for the actual immune process. So if the immune process continues, it eventually we have seen it, it's been shown over and over again, the whole neuromuscular junction may just completely become very deep and very few receptors left. And what will happen is patient will have what we call permanent muscle weakness. Immunosuppressive therapy is what our goal is, full or near full symptom remission. So prednisone is the first line of treatment. And then azathioprine, mycophenolate, I'm going to talk about that. There are other drugs, methotrexate, cyclosporin, tacrolimus, cyclophosphamide, many more. I'm not going to discuss about those because the most common, I'm going to just go over the side effects in detail. If you have any question about these drugs, feel free to ask question. We can go over those. And then intravenous immunoglobulin, rituximab, some patients are. Thymus assessment, thymectomy, and there's been a trial which is placebo control, and it showed efficacy of thymectomy. So thymectomy, I'm not going to go over side effects, it's a surgical procedure. Basically, it's whatever complication, you could have infection or breathing difficulty related to procedures from that. And the reason it is recommended because studies have shown that patient can go into remission or what we call minimal manifestation, that they're leading relatively normal life. Some patient may still have to take medication and some patient can even come off of medication. Why do we need to treat patients? Okay, improve quality of life. Patients has that droopy eyelid, it is affecting work, driving, walking, everything. Reduces risk of exacerbation because immune process is ongoing, damaging the neuromuscular junction. If we don't treat, it could be life-threatening because this can affect your breathing and swallowing muscles. Which I've discussed, if you don't treat it, you can develop permanent weakness. So once we treat it, we're decreasing the risk of developing permanent deficits. And also patients who have just basically ocular symptoms, if you start them, we're reducing risk of generalization of the disease. Okay. So now I'm going to go over different medications and briefly tell you how we give it, the dose, and where it's working, and what are the possible side effects. So pyridostigmine or mestinone, which I mentioned, is basically for symptomatic treatment, and dose can be adjusted according to the response. So usually it's a 60 milligram pill, and we would start, I personally start half pill, because I will go over that, because usually it causes severe stomach cramps or diarrhea. Some patients feel nauseated. And if you start the full dose, it's very hard to tolerate. If you start a low dose, you can easily titrate it up. So I start half pill 3 times a day, and after 1 week, go to 1 pill 3 times a day. If patient don't have side effects and they're noticing improvement, so rather than just increasing prednisone dose or something, if it's minimal variation of symptoms, we can increase the dose of pyridostigmine. It can be adjusted according to the response. As I said, it's a pretty safe drug. It is primarily asymptomatic treatment. So side effects could be stomach pain. Patient could have nausea. Patient could have vomiting, diarrhea. Muscle cramps are very common. Twitching. Rarely we don't see it now. If patients take too much pyridostigmine, you might end up in the ICU. A patient might, because of it's affecting the heart and all these cramps and everything. It's an anticholinergic effect. The patient is having very rapid heartbeat and all sweating, increased salivation, and they have cough with mucus. Some patients, rarely, I've not seen it, could develop rash and blurred vision. So initially, what do we do? Let's say if it helps you, but you're having diarrhea and stomach pain, you can take something over the counter for the diarrhea. And most of the time, what will happen is with time, these side effects get better and you can tolerate it. If the patient is having side effects with it, even with a lower dose, I think probably the best thing is just stop it, because we will not be able to go up. As I said, quality of life, whatever we're trying to achieve will not be achieved. Patient will have more side effects. Now, prednisone is the first line of treatment, and there are different ways of starting it. If patient is, the symptoms are multiple, they're having what we call swallowing, we'll start them at a high dose, and almost always is recommended that should be done in the hospital. If the symptoms are mild, we can start in the clinic. That means patient can start taking it home, but that's a different regimen. So this regimen is that you're going to take 0.5 or 1 milligram per kilogram per day. So patients, maybe depending on 60 kilos to 100 kilo, depending on whatever they're taking, the higher the doses we're putting up with the higher side effects. And this is the one as the patients are having lots of symptoms. If patient has, let's say they came in with just pure ocular or mild generalized symptoms and I want to start them in the clinic, then I'm going to tell them, usually I says take 10 milligram a day for 1 week and then go to 20 milligram a day for 1 week, and then each week keep on increasing. Because if you start at a very high dose suddenly, sometimes they have seen patient could have exacerbation acutely with the respiration. So that's why somebody who who's newly diagnosed with myasthenia, high dose treatment is highly recommended to be done in the hospital or monitored situation. Some patients are given every day or every other day. I have tried both of those. Usually the every other day, the side effect profile is better, but the patient then on the off day, they feel that maybe symptoms are somewhat worse. So I try to give every day with the lowest possible dose. That's what is my aim when I'm treating patients. There are many long-term side effects. So some are like what we call like initial stages, and then initially prednisone, well, patient is happy, doctor is happy, everything is going, but I think there's a lot of long-term, and that's why we always try to taper off the medicine as quickly as we can. So acutely, patient could have sleep disturbances. They said, I'm having difficulty sleeping. It's very important not to take prednisone later in the day. Usually the best thing is take 9, 10 a.m., take a couple of crackers and take medicine. And patient could have some stomach irritation. If that's what happens, we usually almost all will prescribe. You can take either over the counter like Prilosec or any of those to protect your stomach. It could cause exacerbation of mood disorders. So usually patient get a little bit more agitated. If patient have history, some patient could develop psychosis. Like I've never seen frank psychosis, but they may be very agitated. And if that would happen, we have to stop the medication. Long-term, patient could develop glaucoma, which is increased pressure in the eye, or they can develop cataract. Is a very common. The longer patient takes it, they can develop cataract in the eyes. Avascular necrosis, basically what happens is that the bones, they start losing their bone density, and it's just like a kind of necrosis, like a death of that part of it. So our most worrisome for physician is it could be avascular necrosis of the hip joint. And if that breaks, that affects mobility and has a very long-term side effects. So patient develop like thinning of the bone, osteoporosis, or could have osteopenia completely, and pathological fracture. Patient could get what we call the elderly patient could also get fracture in the spine, what we call compression fracture. I mean, they just suddenly have severe back pain and you do x-ray and they will have the vertebra, because it becomes a demineralized kind of thing. Whatever your cement type of thing was, that's your calcium, all that's gone. It just collapses. When it collapses, it's causing pain. It's putting also your nerve fibers may be affected. There's a different treatment for that. Usually it's orthopedic surgeons, spine surgeons usually can inject something into spine to treat that. Hypertension is another dreaded complication of long-term steroid treatment. If prednisone is helping and we cannot lower the dose and patient develops hypertension, then they're treated by a primary care physician with the appropriate medication. I mean, they look at the patient as a whole, what's which is good for this patient or which is not good for this patient. You know, somebody has kidney damage, what medicine should be given, or they have some other medication they're taking which is going to interact or not. Another common side effects could be diabetes. So first patient develop high glucose or hyperglycemia. They might become pre-diabetic or frank diabetes. If your patient is pre-diabetic, before starting on that, they might just turn into frank diabetic soon after that. Prednisone, the way it works, patient could have potassium, low potassium level can give you muscle cramps. You might feel weaker. That's why usually we check that and either we give potassium replacement. And usually I recommend if you're taking prednisone, just eat banana a day. That usually will take care of it. If not, but we keep an eye on the potassium level. So how do we prevent it? I went over that. We should do DEXA scan at baseline and yearly while patients are receiving corticosteroids. It should be part of like a guideline at least, and most of the patients, sometimes the insurance company won't allow it, but every 1 or 2 years we should do it, especially patients, menopausal women. Patients should take calcium, preferably 1 gram per day or at least 600, and vitamin D 400 to 800 units are for prophylaxis against steroid-induced osteoporosis. The bisphosphonate, that's another for postmenopausal women, which helps with the health of the bones. Proton pump inhibitors are like Prilosec and all those I'm talking about. We'll give it to patient to protect your stomach. It doesn't get irritated, it doesn't start having bleeding. Periodic, just make sure we tell the patient, make sure you see your ophthalmologist at least once a year. Fasting blood sugar, and it should be monitored. And potassium supplement if it's required. If you see that the patient is consistently, the potassium is going low, you should order that, or you should take that. Next medication is azathioprine, Immuran. Most of the patients take it as an old medication, but I think most of the studies have shown. So let me just back off a little bit. Why do we need to put on these when we call these chemotherapy or immune modulating therapy? The main reason is that we want the prednisone to go down or completely be tapered off. So then we don't have to put up all those side effects. So azathioprine has shown, it's a very good drug and patients have shown improvement. All of these immune modulating therapies would not show effect immediately like prednisone. Some usually take, we say, about 3 months, sometimes even longer. So once you're placed on azathioprine or any other medication, don't expect the prednisone dose will be decreased immediately. It takes a few weeks to months before these medicines start working at the level they're supposed to, and patient can be safely tapered off of prednisone. So basically what it does, just briefly, one is the T lymphocyte, which controls our cells inflammation, and B is like what antibodies. So it works from the T cell, because T cell, we also look at we have shown that involvement in myasthenia too. Basically initial dose, as we said, 25 to 50 milligram daily, or we could start 50 a day or 50 BID. And the incremental goal, depending on how patient tolerate it, you can go to almost, I usually go to 100 twice a day, but you can go up to 250 a day if you have to increase the dose. Now, what are the side effects of Immuran or azathioprine? Nausea and loose stools are the most common patient complain about. This is another one, about, as I said, 12–13% of the patient feel like a flu-like systemic reaction in the first 2 weeks of therapy. If that ever happened, usually I would try to treat it symptomatically. You can give Tylenol or something else and see if some patient, I would say 1 or 2 patients over the last 35 years have said that they would not take that otherwise most of the patient tolerate it. So it's like, you could say maybe 1 out of 8 or 9 patients will have those symptoms. This is very important. If your physician is we're starting a patient on azathioprine, we check for TPMT. This is an enzyme. If patient has this enzyme deficiency, that means that patient has a higher risk of developing bone marrow suppression. So then we don't, those patients, we don't treat with that. So this is just like a simple test. Insurance will cover it. It's a blood test, we check it. And if the level comes back normal, we can start the patient on azathioprine. All this chemotherapy immune modulating, they could have these side effects. So azathioprine is, if you're taking patients, taking while they're pregnant, it can have teratogenic or may affect on the fetus, maybe. So that's why we tell patients, you will, if they're even planning to get pregnant, they have to come off of this medication. And also could cause malignancy. So that's why patients are monitored regularly. It can cause inflammation of the pancreas, which can cause other side effects, and liver toxicity may develop within a few months. Bone marrow suppression can develop within weeks, but may also take 2 years. So that's why patients are monitored monthly for the first 3 months and then every 3 months. Lots of patients get tired of getting this blood drawn, but it's very important. Just think, because if it takes 2 years and we get just very comfortable after 1 year, 18 months, or nothing is happening, that might start causing effect on the bone marrow or liver, and then it's much more, complications here. So if the blood white count drops below 4,000, are we going to hold the dose? If it will, and we will watch it. But if the dose is decreased, but if it drops below 2,500, we hold the medication. Or if liver function tests have increased to twice the baseline. So if they started 50 and it turned to 100, we'll stop it. And that toxicity may take a few months to reverse. Some patients, I usually do not re-challenge them because thankfully now we have many more medications. If there are very few choices, you can't re-challenge, but you have to keep a very close eye on the patients. Okay. The next medicine I'm going to talk about, mycophenolate, Mofeto, which inhibits T and B cell proliferation. So remember, B cell antibodies, it's initiated 500 milligram twice daily and then increased by, usually our goal is to 1,000 milligram twice daily, sometimes 1,500 milligram twice daily. With patients who have kidney dysfunction, we have to make sure we don't go above this dose because of it is excreted through the kidneys. If you are into literature, you might have seen it that when the studies were done, as mycophenolate is CellCept, it was read as if it did not show effect. And the criticism of those 2 studies were that it didn't give enough time. It was 6 months, and they think it should have been at least 1 year. But remember, I told you these medicines take much longer. And patients have been taking it, and we have seen effect on patients, and we are able to decrease the dose of prednisone and much better tolerated too than azathioprine. What are the side effects? Mainly nausea and loose stool. Severe infection can occur. Any immune modulating therapy lowers your immune system, including prednisone sometimes, and you're at risk, patient is at a risk of developing infection. Patient on a mycophenolate Mofeto should be monitored for low white count and liver dysfunction. So women of childbearing, exactly the same way azathioprine, should use 2 forms of birth control, and pregnancy should not be planned before withdrawal. So any of those medication, if patient is even if you're thinking about it or considering, should come off of those medications. Now, intravenous immunoglobulin, most of the time it is treated for what we call crisis or worsening of symptoms. Some patients are given this as maintenance, but class 1 study, which is the most strong evidence, has not shown that, it has not been done for that. So what class 1 study for IVIG says is probably effective treating myasthenia gravis, evidence is insufficient to compare the efficacy of IVIG or plasma exchange. And I'll show you another study which showed that maybe plasma exchange was a little bit better. So role of IVIG in chronic management or as a steroid sparing drug, not yet established. I mean, there are trials going on, but basically now more medications are coming into market. And so it probably will be very few patients who will fulfill the criteria for that. We do not know IVIG, how it will do patients who what we call seronegative, that they are still good receptor antibodies, MuSK antibodies, or LRP44 antibodies are negative. MuSK positive patient, we don't use it. The treatment for MuSK positive patient is plasma exchange. So this is like recommendation is it should be considered in the treatment of myasthenia, which is a level B, which is one level below level A, which is the maximum, strongest evidence. What are the side effects of IVIG when we give them? So most important as a patient who will be given IVIG, they are tested for what we call IgA deficiency. Because if we give patients who have IgA deficiency and we give IVIG, then what will happen is that they will have this, it's a kind of, you already have antibodies there, and then this IVIG is going to go and attack there, and your patient could have a severe reaction to that. Patients who have kidney dysfunction, it can cause actually more effects, so we have to consider about that. Heart failure, we have to decrease the fluid content, so you might give, if we really have to give it, we give a concentrated IVIG, so there's not enough fluid overload. What are the side effects? Patient could feel like headaches, they feel like muscle aches, myalgias, fever, chills, nausea, vomiting, common up to 50%. So patient could be given acetaminophen or diphenhydramine before the infusion of the IVIG. They could develop aseptic meningitis and thrombosis or DVT in the leg, and the clots can go to the lungs. Because of that, thickening of the blood, patients are at a high risk of heart attack and stroke. But as I said, these are very uncommon, and every day hundreds and thousands of patients are given this procedure with safe infusion. Excuse me. This is plasma exchange, and what they have shown that the plasma exchange is was superior on patient who took, on their breathing was better. Excuse me. Side effects are high with plasma exchange because in an invasive procedure, your blood is taken out, is clean. So basically, could have, difficulty with some blood clotting and those things. So this is always done, plasma exchange is done, is always in hospital or infusion center. Now, in the interest of time, and these are like actually very new medications, and I'm going to go briefly over that. But this is very exciting time for myasthenia gravis, patients and the physician who treat it. We're looking at complement inhibitors, neonatal FC receptors, agents, and B-cell interfering drugs. I know those are very big names, but I'm just trying to keep it simple for you and tell you how these medications work and what are the possible side effects. So complement is which takes part in our immune system. The medicine which complement I'm talking about, we have different pathways, classical, alternate, and this is like a binding lectin pathways. It starts from complement 1, 2, 3. There's a complex keeps on making it. Once it reaches to C5, when it breaks down to C5 and B, that's when it starts what we call lytic or breakdown. And that's what creates a membrane attack complex, which is causing damage at the neuromuscular junction and basically causes damage to other immune mediated. So these complement inhibitors medicines are basically that they're trying to affect this so it doesn't convert to this or C5b. It stops this process. So that what happens is you don't have any breakdown or killing of the tissues and patients could improve. So the medicine, as you might have heard about, is eculizumab or Soliris. It's a monoclonal antibody that binding to C5 fragment, which I showed you, and it prevents its breaking down and subsequent neuromuscular junction damage, okay? It's not a new medicine. It's been used for, other medications and like kidneys and other, and children have taken it. And now it's also used in, it's kind of what we call neuromyelitis optica. It's not MS, but it's a different spectrum disorder. And it's used, so it's approved for refractory acetylcholine receptor antibodies. Okay. It has been clearly shown tolerability and improved in clinical trials. It's given 900 milligram per week for 4 doses and then 1200 milligram for 2 weeks. Side effects, that's where you have this warning. Patient could develop Neisseria meningis, which is meningitis. So you have to be vaccinated 2 weeks prior to first dose, depending on whichever vaccination it is, depending on what your physician sent you. Finish the course, and we usually wait for 2 weeks and then we start it. It can be given if a patient is admitted with severe disease, but then what we do in the hospital. I have not done it. I stabilize the patient and then later on we start them on this drug, okay? Patient could have a headache, patient could have very common nasopharyngitis or muscle aches and pain are very common with this disorder. There's another medicine, the same class. So its half-life is longer than eculizumab and the studies are going on. It's been approved for other disorder, which eculizumab is also being used. So once it comes as approved, the treatment will be every 8 weeks instead of every 2 weeks. So it cuts down on the patient's treatment and the burden of treatment is much less. So basically what is the recommendation? Complement inhibitors, which I discussed, considering their greater target action may represent one of the largest steps towards immunotherapy because they specifically go where it's attacking the neuromuscular junction. So that may be eculizumab, and when the revolutimab is approved, maybe approach to treat acetylcholine receptor related refractory myasthenia gravis, because eculizumab is approved only for acetylcholine receptor antibody positive generalized myasthenia gravis. Briefly, the last one, this is called FC receptor. That's another one. It's a very interesting and very exciting time. Basically, what happens is the pathogenesis, this is that once we have this pathogen, let's say your antibodies or anything, it attacks these antibodies, is attaching to that. And it causes inside, you will have this immune complexes, IgG and IG, all those keep on making and keep on prolonging your immune process. If we stop that, we'll stop that process. So this is almost like getting plasma exchange. So without all those tubes and anything, you're getting this treatment and it's clearing your blood and system out of those B and all those antibodies like you're getting the plasma exchange. So that's what's called FC fragment is against that IgG1 derived fragment. Basically what they showed, rapid and sustained decrease of IgG levels and antibody levels also, and patients showed improvement, clinical improvement, different myasthenia gravis. So most common side effects with these medications was headache, a reduction of monocyte blood white count. And it's better tolerated. And as I say, it is like in the short-term immunotherapy, overcoming the limitation of plasma exchange or IVIG. So if it is tolerated, everything, it might be all these invasive procedures just might take its place. It's a shorter duration of efficacy, repetitive doses you can give at large ones. So you don't have to go through all those things. Okay? It's considering that this will cause, remember I say it's IgG depletion, there might be a good candidate first line in long-term immunosuppression therapy. So it might not be that if you're refractory, it will be that we'll just start it. Once you put on prednisone, we're just going to add it after that. As any new medication, we don't know high cost, what are the other adverse effects during chronic therapy and any other antibodies that patients will develop to that. which we learn with time. And rituximab is the medicine patients take it. This is for the B cell. And basically, this is approved for other medication, but it's not approved for myasthenia gravis. It's used in other cancers. But it has shown on myasthenia gravis, it's shown tolerability in acetylcholine receptor antibody positive, refractory myasthenia gravis, also MuSK antibody positive patients has very good results. And basically, I'm just going to show it that it has shown improvement with that. Patients who were treated with rituximab in early phase of disease, rather than waiting when they become refractory, they had much better outcome. So if we have to think about it, we should think about earlier. And I think patients who are severely affected, maybe early in disease process should be given. And basically the side effects were flushing, allergic reaction, headaches, fever. They could have heart attack, can develop diabetes or hypertension. And because like any other immunosuppression, we are depleting, we are taking away the immune system. Patients are at high risk of infection. They can get herpes zoster, which is like your shingles. And also it's a tumor in the brain, which is related to JC virus. So we have to watch patients for that too. I'm going to stop there. Any big question, comments, I'd be happy to answer.
Thank you, Dr. Hayat. That was such a thorough and educational presentation. Yeah, we'll just go ahead and open up the floor to the participants to see if anyone has any questions. Feel free to ask, Dr. Hayat, any questions you may have about what you just learned, or any questions about specific MG medications and their side effects. Usually give people just a minute or two. And again, you can just type in the chat box if you have any questions, or email Allison via email too. That always works. Dr. Hayat, I think you made a great point about how exciting it is for the MG community, given all the drugs in the pipeline right now.